Thank you for the kind invitation, Sarah. I really appreciate it. Can you hear me okay? You can hear?
We can hear you fine, John.
Yes, loud and clear.
Okay, I'm a little paranoid about that. Okay, it's great to have the invitation for New Horizons. New Horizons I have a fondness for because from the beginning of GIST and CML, New Horizons has really been at the cutting edge, ensuring that patients are advocated for through not only clinical care, but also partnering in research that has led to many of the breakthroughs where we are today. It's also to me very heartwarming to see so many different groups to work together collectively towards a common goal. And it's been a privilege for me to have participated in some of these really fabulous meetings. So I'm going to begin today discussing new agents. I know you've heard a lot of background about GIST and GI stromal tumor, and I'm really going to be focusing on advanced or unresectable / metastatic GI stromal tumor. But I'm going to, before we talk about the new agents, I'm just going to take a step back and share a few things that I think are important for the landscape of the discussion today. Okay, so you've heard most of this already today. I'd like to emphasize again about gene mutations. And I'd also like to just set the landscape of treatment for patients with advanced or metastatic GIST with tyrosine kinase inhibitors. One barometer we use of the effectiveness or activity of a medication is called progression-free survival, or median progression-free survival, more correctly. And that's the point at time from when a patient first took a medicine to that point in time when the tumor starts growing again. And just to put it in context, prior to imatinib, that time was about 2 months. And now with imatinib, it's 24 months or more, some would say. Sunitinib, 6 months, median progression-free survival, the time at which half of the patients have had their tumor grow again. Regorafenib, it's 5 months. Well, now we have ripretinib, which is in 4th line, 6.3 months. And we have Evapritinib in 4th line and later, 3.7 months for GIST in general, just patients in general. Now, look at Evapritinib and in the Pdgfr mutant patients, and I'll show more details of this data later, but that progression-free survival hasn't even been reached yet. From when that study started, more than half of the patients are still progression-free. Really remarkable, considering just maybe a year or not even that long ago, there was no treatment for patients with Pdgfr mutant GIST. This is my perspective on the different GIST subtypes, and this is the way I think of the primary mutations and the secondary mutations. And we're learning more all along. I suspect we'll be adding to this. This is important because the subtype and the mutation really drives the treatment. Even within KIT, we know patients with exon 9 mutant KIT do better with 800. And you have to identify Pdgfr because we have a treatment for these patients. SDH deficient GIST is incredibly important, and we're still trying to find the best treatment for these patients. And you have a number of other types of GIST. Importantly, one of the newer players on the block is the TRK fusion GIST, because we have larotrectinib and trectinib, other TRK inhibitors on the horizon. And you don't know a patient, and a medical oncologist really has no idea what optimal therapy is for patients with GIST unless you have the mutation data. Imagine adjuvant GIST, taking imatinib for 3 years without knowing whether there's a Pdgfr mutation or a KIT or a REF. A patient could be spending in the US $300,000 in 3 years of side effects for no known benefit. And then the metastatic setting, when a patient, for instance, recently I had a patient that had been treated with imatinib and sunitinib for NF1 mutated GIST. And of course, these medicines didn't work, and they wasted valuable time and caused a lot of side effects. So this is critical. And at Sylvester, for many, many years, since even before I came here when I was at MD Anderson, every single GIST patient who's being considered for a systemic therapy, whether that's adjuvant or metastatic, needs to know the mutation status. It's just not acceptable not to think otherwise. Now I'll share you some really eye-opening data. This is from the United States. This is data that we published earlier this year with Jorge Florendez, who is a database whiz. We looked at the National Cancer Database in the US and found that only 30% of GIST patients are getting KIT mutation testing. And you can see that this bar graph is relatively flat. It's not going up, despite the fact that we know we have targeted agents, and we know that we need to know the mutation to know whether a medication works. And this is real US data from our National Cancer Database, and it's really disturbing as a medical oncologist who specializes in taking care of GIST patients. This is all comers. The exact same percentage, 30%, holds true when we look at patients with metastatic or advanced GIST. 70% of patients are on a medicine for which we have no idea what the probability is that it's going to help them or whether it's going to help them at all. The good news is that there are emerging technologies that are allowing us to detect tumor mutations, even in a non-invasive way using circulating tumor DNA. I realize you heard about this some earlier today, but I just wanted to re-emphasize the emerging technologies. Every patient at Sylvester who progresses on a TKI, we perform circulating tumor DNA testing for reasons I'll discuss subsequently. One reason is to know the KIT mutation status. Now, circulating tumor DNA does have some non-detectable specimens, but when we do detect a specimen, do detect a mutation in the blood, from our research published by Dr. Arshad, we found 100% concordance with what was in the tissue. So it's exceptionally accurate, and and we found that most mutations detected in blood are KIT exon 11. We found a lot of other mutations, some of which might have been noise, but KIT exon 9 and Pdgfr. And yes, this question comes up to me all the time. Pdgfr mutations can be detected by circulating tumor DNA, as you can see in this pie chart. Now, what happens when the patient has already had imatinib, sunitinib, regorafenib, and we start doing resistance mutation testing? Well, we find that about almost 60% of patients have exon 17 mutations, and about a third have exon 13 mutations. I know you've heard about these two different flavors of resistant mutations. They're the most common, but there are other mechanisms. There are certainly other mechanisms of resistance that remain poorly understood. This is a heat map that I put together, and we published earlier this year in JCO Precision Oncology, and it's based on in vitro data, in vivo data, and our experience at Sylvester. You can see it's been influenced by Cesar Serrano and Michael Heinrich, and others have helped us shape the way we think of mutations across the top and agents across the left side of the table. Importantly, all of these agents on the left side that you can see listed here are active against KIT exon 11. There's no doubt about that. We typically give medications in a certain order: imatinib, sunitinib, regorafenib. But if there is a reason to give a different medicine in a different order, be assured that exon 11 is sensitive to all of these agents. Now, when a patient becomes resistant to imatinib, you see the first row, there is resistance out here on the far right. Red is resistant, okay? Red is bad. And imatinib resistant can be in exon 13 or in exon 17. I put 14 and 18 there because there are rare cases, but it's the same conceptually in these areas. Now, sunitinib, you'll notice in the next row, is green in exon 13. It's very active at KIT exon 13 resistant mutations. Now, if you look at everything past sunitinib, everything from regorafenib all the way down to evapritinib, you see less certainty about activity at exon 13. There may be some, I suspect there's going to be some data presented soon, perhaps at CTOS, on the activity of evapritinib at exon 13 resistant mutations from the recent couple of studies that have been completed. The Plexicon drugs we're still not sure about, but from our experience, there is the most certainty of the activity of sunitinib in exon 13, and we're going to have to follow evapritinib and see the updated data. But these other agents that are red really are not very active at exon 13. Now, if you go out to the right at exon 17, sunitinib is not very active at exon 17. However, the other agents down from, in the same column, down from sunitinib, most of these do have pretty good activity at exon 17. So this is another emerging use of circulating tumor DNA, is the potential identification of an effective therapy. Now, that's considered experimental and it has not been validated in clinical trials, although we hope to be able to do that soon. Now, I'll discuss, we'll get down into the details a little bit about some of these medications. These slides are going to be busy. They're in the public domain, so we can make them available. Certainly, I will discuss what I think is important. And so this is the Invictus study in patients with metastatic GIST who had progressed on at least 3 prior treatments. Imatinib, sunitinib, regorafenib were randomized in a 2-to-1 fashion to receive evapritinib 150 milligrams a day or placebo. Patients were followed for disease progression, meaning growing of the tumor by more than 20%. And then patients were unblinded, and if they had progressed on evapritinib, they could dose escalate, or they could discontinue, or continue if there was some benefit in the eye of the treating physician. Now, the patients on placebo at 28 days, if they progressed, they were allowed to cross over to evapritinib 150 milligrams per day or discontinue the study. And then at disease progression, we're back in the same boat where there is escalation, continue on the same dose, or discontinuation. This is a busy slide just to show that this is a fairly common GIST population. The majority of patients in this study were Caucasian, and most patients had 3 or more therapies. All patients had 3 or more therapies, and some of the patients were more challenging performance status. Most of the tumors, and there was fair balance. You want to look at the balance between the 2 arms, evapritinib and placebo, fairly well balanced in terms of the distribution of the anatomic sites, the size of the tumors, and the mutations, importantly, fairly balanced. Now, this is the data that's been published, and this shows a median progression-free survival of just over 6 months versus only 1 month with placebo. Well, the first time a CAT scan was done on a patient on a placebo on this study was at 1 month. And so the majority of patients, about 60%, had already progressed and had tumors growing 4 weeks onto placebo. 2/3 of those luckily were able to cross over to receive ripretinib. The complete and partial response rate for ripretinib ended up being about 9%, which is pretty common with TKIs, and it's actually higher than what initially was reported using this type of criteria, RECIST. Not surprising, placebo showed no responses, but you just see a lot of stable disease in patients, sometimes out to 12 weeks. And these are the patients that had PR or CR. These are the 9 patients that benefited. And you can see that some of these patients are out here more than 12 months and still responding and still benefiting from therapy. And then this is the showing an overall survival separation that is statistically significant. Patients on this study lived longer when they were randomized to a active agent, ripretinib, than when they were randomized to a placebo. Let's talk side effects a little bit. Again, this is very busy. You can see the 2 most common side effects are hair loss, muscle aching. But if you look at what we would consider significant side effects, grade 3 and grade 4 means that the patient is affected by the side effect in terms of their quality of life, meaning they have to take an extra medication to manage the side effect, or it's making them have to go into the hospital or go into the clinic. And so that only really occurs in 1 to 2% of patients with these side effects. So thank goodness the grade 3 and 4 side effects are rare. We do monitor some blood tests, namely lipase, as this in this study did affect the pancreas in a few patients. Here's some other more rare side effects. Again, 1% of patients, only 1 patient in the study. So these are all very rare, although some of them are pretty significant, such as bleeding, kind of thing. These are the questions about these side effects, are the questions that just medical oncologists ask their patient about. So when I see patients in clinic on ripretinib, I do these blood tests. I do a physical exam to try to detect ascites. I ask questions that might suggest cardiac failure or skin infection. So these are the questions, these are the reasons that the doctors and the nurse practitioners ask all those questions, is we're monitoring for these side effects. So the bottom line about the Invictus study is that it showed that ripretinib was statistically significant in terms of progression-free survival, overall survival. There was not a significant response rate, but that's not uncommon when we use RECIST. So it is now FDA approved in the United States for 4th-line therapy for GIST. Patients that respond can do so for a durable period of time. Now let's talk a little bit about Navigator. Navigator is a study of Evapritinib, and this is a phase 1 dose escalation and expansion study. Advanced GIST patients, meaning they can't be resected or they've spread to multiple organs. Patients must have had a mutation in KIT or Pdgfr receptor. And really the goal of, one of the major goals, if not the major goal of the phase 1 study, is to determine the recommended phase 2 dose. You can see here in pink. The analyses were performed on 4th and later line GIST and Pdgfr receptor alpha exon 18 mutated GIST. And so these are the characteristics of the patients. And again, this is just to make sure we're dealing with a reasonably similar patient population as what's out there in the world, and to see the amount of disease. So these patients had pretty large tumors. Over 50% had greater than 5 centimeter tumors. Patients, majority had prior surgical resection. And in this subset, we're looking at the Pdgfr mutated patients. And so this is Pdgfr. And so now, again, the side effects. Again, side effects are common with any medication when you look at all grades. Let's really focus on grade 3 and grade 4 treatment-related adverse events over on the far right. And you can see the most common side effects are fatigue, anemia, and importantly with Evapritinib, we're all aware that there is a rare but serious impact on cognitive effects in some patients. Thank goodness it's rare, but we do have to recognize it because it's manageable. Diarrhea is manageable, and those are the common side effects. Now this is where it's really exciting. This is best data that we've seen since imatinib was used initially in tyrosine kinase inhibitor naive GIST patients. And so in this plot, you can see that a bar graph that goes up is the percentage that a tumor grew. A bar that goes down is the percentage that a tumor decreased in size. And so it's exciting to see that 95% of patients had some decrease in tumor size. If it decreased past this 30% margin, it's called a partial response. And 86% of patients had a partial response or better. And in fact, 3 patients had a complete response, meaning all tumor undetectable by CT, MRI, or PET scan. A lot of stable disease, only 1 patient met the criteria, again, 20% growth in a study for progression. And this is looking at Pdgfr exon 18 mutated patients by line of therapy. You can see that patients with Pdgfr alpha mutated GIST benefit from Evapritinib, whether it's in first line or second line. There is a partial response, complete response. Nobody progressed in first line, although it's a small number of patients. Very few patients progressed on second line. So this is clearly an incredibly active agent for those patients with Pdgfr exon 18 mutated GIST. And this duration of response is quite long. You can see this not even reached the median yet. So the median is the number we give for progression-free survival. So when this bar graph drops below 50%, meaning that more than 50% of patients have had their tumor grow, then that's the median progression-free survival. Well, we're out to 20 months, and there's still no indication that it's going to reach that 50%. Remember, with imatinib, that number is, in all comers, independent of mutation, that number is 24 months. So I'm fairly confident that Evapritinib in selected Pdgfr exon 18 mutated patients is going to exceed 24 months in median progression-free survival. Now let's talk about Evapritinib in fourth line with KIT mutated patients. So this is not the Pdgfr D842V exon 18. These are the other patients with KIT exon 11, KIT exon 9, resistant mutations in 13, 17. And in this arm of the study, in this cohort, what we found was the partial response rate of 23 patients out of 111, with an objective partial response and complete response rate of 22%. Clinical benefit rate, meaning partial response, complete response, and lack of progression, 41% of patients benefited. And again, fairly durable. But the median progression-free survival, when you look at all comers, is 3.7 months. But the patients who did respond for a long time with a median duration of response of 11 months in the subset of patients who responded to this agent. So in conclusion, Evapritinib from the Navigator study showed us that there is incredible activity, favorable tolerability in PDGF receptor alpha exon 18 mutated GIST. It also showed that there is definitely some activity, a 22% response rate in unselected patients with Evapritinib in fourth line and beyond. The safety is predictable and manageable, but it is a little different. Each of these TKIs have a little bit of a different pattern in terms of side effects. Recognizing them, acting quickly on them, and undertaking a preventative strategy to prevent side effects is really the optimal approach for patients with advanced GIST. So I'll share with you a couple of specific situations where, you know, the direction I think that we're going. We have now 5 agents, 2 new agents to use in the way that we treat imatinib and the way that we treat GI stromal tumor. The future, I believe, is going to be in understanding the resistance. Right now, the biggest lead we have are the resistance mutations, exon 13 and exon 17. And I believe that that pattern and the side effect profile are really going to help us select the optimal patient, the optimal medication for the best patient. So this is a 55-year-old man with a gastric GIST that had KIT exon 11 mutation, progressed on a number of agents. Circulating tumor DNA revealed an exon 17 mutation. So this is the far right of the table. At the time of this treatment, Evapritinib, Ripretinib were not available yet. You can see the red pointing to the tumor. This is the patient's back. This is the patient's right. This is the left. They're looking up. This is a cross section through the liver. So this patient we chose to treat with ponatinib because of its known activity against KIT exon 17. Even though the patient had had these other agents, which may have had some activity at 17, but remember regorafenib had a little bit of uncertainty with some of the mutations. And so you can see that not only did the tumor nodules get smaller, they got darker. And we all know that tumors losing contrast enhancement is equivalent to a partial response when they go below 10%. And then even better after 12 months and has been on the medicine for more than 2 years. Very effective therapy in this patient. Now here's another patient with metastasis in the liver after progression on imatinib. This patient has a KIT exon 11 mutation and then progressed on imatinib, was placed on a different TKI at the time empirically, and ended up having progression. We saw the patient, did circulating tumor DNA immediately, found a KIT exon 13 mutation. And so we knew that at this time we had figured out that sunitinib is active at KIT exon 13 resistance mutations. And so we put this patient on sunitinib. She's had a great response to therapy and is doing great today. So in conclusion, primary and resistant mutations should be determined in order to provide optimal therapy for our GIST patients. Liquid biopsy, circulating tumor DNA, is a rapid and non-invasive tool to detect mutations. Evapritinib and Ripretinib are new active agents for GIST patients. But there's a lot of questions that remain. You've had 2 full days of lectures about GIST, and each of us giving a presentation, we have a dozen questions that we still have to answer. For instance, these newer agents, Ripretinib and Evapritinib, should we be using them in earlier lines of therapy? I would say for Pdgfr D842V, we should be using Evapritinib in frontline. And I'm not sure that we're seeing that widespread throughout the community in the United States. Neoadjuvant or adjuvant, is there a role? If a patient has a high-risk primary GIST of the stomach and it's bigger than 10 centimeters, there's 12 mitoses per 50 high-power fields, and the patient has Pdgfr D842V, should we treat them with 3 years of adjuvant Evapritinib like we would if it was KIT mutated with imatinib? We're never gonna, it's unlikely that we're ever gonna have an adjuvant trial for Pdgfr, but at the same time, we have to take care of patients. So can we extrapolate that data? And I would argue it should be considered. And what about combinations? We've seen sunitinib very active at exon 13. We've seen regorafenib, avapritinib, ripretinib, very active, ponatinib, very active at exon 17 resistant mutations. Is it time for us to do a combination and try to cover all of the potential resistant mutations? Well, possibly that could be a doable clinical trial. And so many questions remain. I'd like to end by thanking the GIST and Sarcoma team at Sylvester, who I'm representing today, as I am presenting our approach to patients and some of our data at the GIST Center at Sylvester. And I'd like to thank them for taking such excellent care of our patients and doing the clinical research and doing the laboratory research necessary to advance the field. And I would be happy to entertain any questions. I'd like to thank all of the participants for joining. 60 people is a great turnout for a New Horizon, the first ever New Horizon Zoom meeting. And so I'm delighted to be here with you guys, and feel free to ask any questions or reach out to me on email or Twitter. I'm always tweeting something about GIST, so you can feel free to follow me there. And thank you for the opportunity.
Thank you so much.